Good evening, everyone. Thanks for joining us in this evening. As five of us have gathered together to host you guys and give you some information about the prostate cancer. As you know, the Prostate Cancer Awareness Month is coming soon, and we have prepared some presentations to give you some information about all aspects of prostate cancer. We will be doing some presentations first, and then we will open up the floor to discussions. Today, I'm joined by four of my esteemed colleagues. All of us treat prostate cancer routinely in our practices. I was joined by Dr. Fadi Beki, Dr. Todd Bro, Dr. Ziad Chouan, and Dr. Ruben Olivares, and we are excited to host you guys. So the first presentation is going to be done by Dr. Becky, and if you can pull the slides up, he will talk to you about prostate cancer diagnosis, and the floor is yours, Dr. Becky.
All right. Can we see the slides?
Yes, we can.
Okay. All right. Well, I can actually not see the slides, so give me 1 second, and we'll see if we can fix this. So I'm going to talk about prostate cancer screening. We're very fortunate for those of us who treat prostate cancer in that we have a reliable screening method, which is actually very unique among cancers. As many of us treat other cancers, kidney cancer, bladder cancer, and the opportunity to have a blood test that does a very good job of not only detecting but monitoring cancer is a real advantage in the world of prostate cancer. So we use a blood test called the PSA, which many of you are probably familiar with, to screen for prostate cancer. But the question of whether that's a good idea or not has not always been so clear. There are pros and cons to screening for prostate cancer. Obviously, the pros are that we detect cancer earlier at less advanced stages, and we can often treat it with less invasive mechanisms when it's detected earlier. With the goal of preventing early morbidity and death from prostate cancer. But the cons are there too. Some patients are overdiagnosed, maybe detecting prostate cancers that they did not need to find out about, because we know prostate cancer can be slow aggressive, certain prostate cancers. Additionally, there's false positives. Other things can raise your PSA, and not everyone with a high PSA who maybe hears that they might have prostate cancer will ultimately be diagnosed with prostate cancer. There are risks to biopsy that we're trying to limit, and we will get into in a little bit. And then finally, not all prostate cancers need to be treated, but once someone has a diagnosis, the temptation to treat it can kind of take hold of both the provider and the patient, and maybe patients who would be better off without treatment end up getting treated for prostate cancer. So we can go to the next slide. Because of this, we have different guidelines telling us when and where to screen for prostate cancer. But these guidelines aren't all in alignment. Everyone here who's talking to you today is a urologist, and we're all members of the American Urologic Association, which has offered some guidelines on when to treat. This is just a summary, when to test PSA. And for the most part, we want to screen men from age 55 to 69. But there's exceptions to that. We don't want to screen patients who maybe have other medical conditions, who have more other things on their plate and might not need to learn about prostate cancer. And then there's other patients who are at very high risk. Maybe they have a family member who has had prostate cancer at an early age, or other risk factors that would make us want to treat or test earlier. This is probably the guidelines that most of us follow the most rigorously, but there are other guidelines like from the U.S. Preventative Task Force, and that's changed fairly recently. It used to be more of a strong recommendation that we screen men from age 55 to 69, and now they only recommend individualized screening for certain patients between that age. And we can go to the next slide. So the test that we use is PSA, that's prostate-specific antigen, and that's it's just a protein that is made by prostate epithelial cells, special cells that are in the prostate. So the advantage is only prostate cells make it, and it can be tested in the blood. And sometimes in patients, an elevated PSA can be an early sign of prostate cancer. But there's other things that can elevate your PSA. Everyone who has a prostate has measurable PSA in their blood. And people who have larger prostates normally have more PSA in their blood. Also, anything that irritates the prostate can cause it to temporarily release more PSA into the bloodstream. So infections, trauma can sometimes lead to false positives, and why we don't want to jump to conclusions just because a PSA is elevated. There's other tests that we check as well that can help us make a decision when PSA is indeterminate. We can check something called the percent-free PSA, which is really measuring how much of the PSA in your bloodstream is bound to other proteins and how much is circulating freely. The lower the PSA that is circulating freely, the higher the risk of prostate cancer. So sometimes we use this when we're not sure if a PSA indicates cancer or not. And that helps us decide whether we should go on to the next step, that is a biopsy. Other things, there's a 4K score, which is a commercially available blood test, again measuring PSA and a few other blood markers, and then taking into account patients' clinical factors, their age, their family history, and trying to determine the risk that this PSA does represent a clinically significant cancer. And then finally, there's the ISO PSA, which I think is the one we use the most here, which is looking for different structures or different forms of PSA, which help distinguish a clinically significant prostate cancer from either benign conditions or a low-grade prostate cancer that maybe we'd rather not know about. And sometimes that can help reduce the need for going on to a biopsy. Probably the biggest thing that's changed in my time treating prostate cancer is the wide incorporation of MRI to screen and to help us screen patients before a biopsy. We used to use MRIs a lot to help understand the anatomy of the prostate before doing surgery for prostate cancer. But now we've standardized the way that we look at a prostate even before considering treatment or even knowing that they have a diagnosis of prostate cancer, and trying to predict the risk that a lesion seen on an MRI will actually lead to clinically significant prostate cancer if biopsied. Additionally, it helps us target our biopsies. Whereas we used to follow a template and take biopsies scattered throughout the prostate, now we know what areas are most concerning for containing a cancer, and we can target biopsies at that area. So as most of us will use an MRI after finding an elevated PSA, and we'll look at something called the PIRAD system, which is a scoring system that you might have heard from your own MRIs that help predict the chance that a clinically significant prostate cancer will be found if a biopsy is performed of that part of the prostate. And lesions are identified on the MRI and then graded 1 through 5, with 1 or 2 meaning that there is a low risk of prostate cancer and maybe we don't need to biopsy, although sometimes we should, and we can talk about that later, or 3, 4, or 5, where that chance of a clinically significant prostate cancer, the kind we'd like to treat, is elevated. Most of us will perform a systematic biopsy where we're still taking biopsies from throughout the prostate, while then using the MRI to target specific areas that are most likely to contain a cancer for targeted biopsies. All right, and I think I'll turn it over to Dr. Schwen to talk about the different approaches we use when we are ready to go on to biopsy.
All right. Yeah, good to be here, and thanks everybody for joining. Nice job, Dr. Backey. I'm here to talk about prostate biopsies. There's a few forms of prostate biopsies that you might learn about. There's the transrectal approach, which is the traditional approach where you have an ultrasound probe in the rectum, similar to the picture to the right. And it seems like the Slides are going the wrong direction here. I'm going to fight that. Okay. So the transrectal biopsy is the traditional biopsy where the needle goes through the rectum into the prostate, and is the more traditional approach. Nowadays, there are some who transition to a different approach called the transperineal approach, which has the same ultrasound probe in the rectum. This picture to the left is actually very inaccurate. That is not a way that people will traditionally be doing prostate biopsies, but the picture to the right is one where there's a transrectal probe still in the rectum. That's the best way to see, but the needle will go through the skin and into the prostate. And this is something that has reduced dramatically the risk of an infection that you can get from a prostate biopsy. Not surprisingly, there's bacteria in the rectum, and when you stick a needle, through the rectum into the prostate, as we would in a transrectal biopsy, there's a possibility that you can seed some bacteria into the prostate. Still an accurate form and an effective form, but does require antibiotics, and there's a slightly higher chance of an infection. There's a recent randomized trial called the PREVENT trial that found that there were no infections in a very large study in the transperineal group, the people who had it through the skin. And most studies agree that the differences in cancer detection are about the same. So really, there might be a slight advantage in some instances where a transperineal biopsy may be able to detect a tumor that might be towards the top of the prostate, called the anterior prostate. This is something that when your needle is coming from the back, it might be harder to reach the top. So this is something that most studies would say that they're similar in terms of cancer detection, but in certain instances, a transperineal biopsy might be the better and more accurate way to target a tumor that either was seen on MRI or can be seen on ultrasound in some instances. Most of these are done in the office, both the transperineal and transrectal biopsies. It's something that mostly it's done under local anesthesia, meaning you're awake and they're giving you lidocaine to numb up your prostate. Sometimes transperineal biopsies can be slightly more uncomfortable for some, and does oftentimes require, having some form of anesthesia given, sometimes in the operating room. But the vast majority of the cases are done in the office, and they're very well tolerated for the most part. As we've improved our understanding of transperineal biopsies here at the Cleveland Clinic, we've started to transition more towards doing transperineal biopsies, especially for people who are at a higher risk of an infection. It's something that has reduced the need to give any antibiotics, and that can lead to kind of breeding more, super bugs that are resistant to a lot of other types of antibiotics. So back in 2024, we performed over 1,000 of these biopsies across the Cleveland Clinic. And we did feel like the trend is moving towards transperineal biopsies, and we do support that. Another form of a biopsy that we can do here at the Cleveland Clinic is using micro ultrasound, and that's something that is a newer type of higher resolution ultrasound. Traditionally, we would think that an ultrasound can't see a tumor or a prostate cancer because, it doesn't have as much definition to it. And that's why we rely so much on MRI. But a micro ultrasound, which is a newer type of ultrasound that's a little bit higher powered, we now know can see prostate tumors without the need for an MRI. Or if you get an MRI, it has a better chance of doing kind of like a fusion where you can see both the ultrasound and the MRI, the lesion. And a recent study has shown that, doing a micro ultrasound based fusion biopsy is about the same in terms of cancer detection as an MRI based fusion biopsy. So that's something that we do think is going to be more commonly done. And it actually, as we study micro ultrasound more, is going to be probably a greater demand for this because it's a lot easier to just, when you have an elevated PSA, just do a micro ultrasound instead of having to go schedule a separate visit for an MRI and then have to come back at another time to do the prostate biopsy. So that's another thing that we do here and offer. And we're looking forward to doing, learning more about micro ultrasound as the studies show up. Just like MRI, there's another type of imaging that we can see prostate cancer, which is called a PSMA PET scan. This is usually a test that's not used until you have a diagnosis of prostate cancer. And traditionally, it's used as a staging tool, something that looks like to see if there's any sign of cancer spread outside of the prostate. So, they do a whole body scan. So we're looking for spots that might have shown that the cancer has metastasized outside of the prostate to another spot. However, more and more we're using it for local diagnosis. So seeing where in the prostate there is a possible cancer, either that was missed before, or it can help us understand a little bit more about what treatment is the better option for them. So this is something that you probably learn about or read about, especially if you or somebody else has a diagnosis of prostate cancer. Not everybody needs them, but nowadays, something that was previously reserved for high-risk prostate cancer is now being more commonly used for people with like earlier and less aggressive cancers to make sure that there, hasn't been any sign of spread, or to better understand kind of where the cancer is inside the prostate. And I think that's it for us. There's something called, liquid biopsies where you can, this is more on the research side, using circulating tumor DNA to also detect if the cancer has spread outside of the prostate, or to detect cancers earlier, and especially screening for multiple cancers at the same time. But this is something that's a little bit more in the, in the future and still not ready for prime time.
All right, great talk, Dr. Schwan. Just to give you an answer, we will answer the questions you're submitting towards the end. So if you're not hearing from us, don't worry, we'll get to that. So I will quickly try to summarize a very long topic. So I'll be talking about, surgery or radiation. So I'll start with the surgery, and the surgery is called radical prostatectomy. So if you look at the diagram on the side, under the bladder, in front of the rectum, there's the prostate, you can see in this scheme. And then the surgery basically removes this prostate. And when there's a gap in the middle, basically the bladder is pulled down to the urethra, and stitching is done so that urination can continue after the prostate is removed. In some cases, the lymph nodes are removed as well in the pelvic area, because that's where the lymph nodes can spread to. And the surgery in modern practice is almost exclusively done robotically at this point, except for some exceptional cases. And robotic surgery can offer a much more tolerable experience for the patient. We do the same surgery as what we used to do traditionally as open, but because the incisions are small, patients have much less pain, much less need for painkillers, much shorter stay at the hospital, and a lot less bleeding is seen with the robotic approach. So the standard robotic surgery is done with 6 small incisions. I put them as 8 to 12 millimeter incisions, just for reference. This is about 1/3 or half an inch in size, these incisions. And with the single port system, we are also able to do it with a single incision as well. So the surgery, depending on the complexity, and each individual is different, but it takes about 2 to 4 hours. And patients come in the morning of the surgery to come to the hospital. This requires general anesthesia, so you have to be fully asleep for this. And after the surgery is done, patients sometimes can go home the same day, or in some cases get admitted to the hospital for overnight observation. Usually the first day we go a little bit easy on the diet, mostly liquid diet, and the next day we transition patients to solid food. There's 2 different surgical platforms for this. Like I mentioned, the one on the left represents the single port robotic platform. The one on the right is the XI platform. That's the standard one that I mentioned in the previous slide. The advantage of robotic surgery, as I said before, is the painkillers are usually mild painkillers. Opioid medications are not always necessary. And like I said previously, most patients stay overnight. We do place a catheter towards the end of the surgery while the patient is asleep, and this catheter stays up to a week in most cases. Obviously, there are some technical factors or surgeon preferences can move these days a few days less or more, or based on unique cases, it can sometimes stay a bit longer. But most patients go home with their catheters. We teach you how to manage them, how to empty them, what to expect before you leave the hospital. And majority of the patients, they come to the office to get their catheters removed at this 1-week follow-up. Majority of the patients do not take painkillers anymore, although there's some discomfort is there with the catheter. Obviously, pain threshold is different for every patient. So there's that. So, the surgery it's one of the most common surgeries we do robotically, mainly because prostate cancer is a very common cancer in men. Short-term complications can include bleeding, which is usually mild. The risk of blood transfusion is about 1% or less, so it's not very common to have significant amount of bleeding. Urine leak can happen from the stitching that I mentioned before. Again, in modern experience, this is very rare and it doesn't happen often. It's most cases self-limiting. Infections can happen on the incisions or inside the body. Again, we don't see these often, but these are possible risks. Blood clots can happen in legs, so we do take precautions to prevent them. We do compression devices on patients' legs during and after surgery, and we administer blood thinners during the surgery and in some cases afterwards as well to minimize these risks. Just like any surgery, anesthesia complications can happen to anyone. And in some cases, fluid collections can happen within the pelvic area of the patient, where it's usually seen when we remove lymph nodes as a part of the surgery, and it can warrant a prolonged drain stay in some cases. These are the very early complications that can prompt longer hospital stays, but like I said, they're not common. But once the things that patients experience the most is when the catheter is removed. So initially, in the early period, patients do experience incontinence. Incontinence means involuntary leak of urine, and it can be caused by coughing, sneezing, laughing, hiccups, lifting heavy things, or standing up. Anything that increases abdominal pressure can cause basically urine to be leaked. So most patients put a protective pad in within their underwear. It's usually not severe that pad can soak it, and it's changed as it gets wet. And over time, it does recover fast. In some cases, it can accompany an urgency, meaning with a sudden uncontrollable need to urinate. And by the time patients make it to the bathroom, they may not be able to hold it. These usually resolve in the first year. Based on our data, about 80% of patients regain the majority of their urine control within the first 3 months. But in some cases, it can last longer, sometimes up to a year. And in rare cases, we can see persistent issues past the 1-year mark. The second part of the surgical experience, the quality of life impact, is about erections. The nerves and the vessels that help us get erections as men, they're by nature stuck to our prostate. And during the surgery, we make all the effort to spare these nerves and vessels. So you may have read it as nerve sparing surgery. So doing that nerve sparing increases the chances of successful erections after the surgery. The complexity of nerve sparing is different in each patient. These are determined based off of patient characteristics, biopsy characteristics, what we see on MRIs, etc. Erections do take a little bit longer time to recover as opposed to incontinence, and we do give some erection medications postoperatively, which we'll cover in the survivorship part, so I won't get into it too much now. In patients who get erections, they may have dry orgasms, meaning that when men ejaculate, nothing comes up. Or in some cases, urine may leak during orgasm, which is called climacteria. Penis shortening is reported after surgery or radiation treatments. This is related to the blood supply issues that's caused by these treatments. And some of the rehabilitation that's done after the surgery is known to be protective of this. Again, we can cover that later. Radiation is the alternative to surgery. And radiation, in its essence, is use of X-ray in a precise fashion. So radiation causes DNA damage, and then the DNA doesn't repair well, which is a normal mechanism in our cells. And there are different methods of radiation delivery. So the most common approach is called the external beam radiation. So the majority of the patients, the technology that we've seen in the last decades, they use what we call a linear accelerator. What that means is a machine outside of the body targets the prostate and focuses within the prostate area to direct that radiation, the X-rays. Proton therapy is a more novel treatment. It's not known to be more efficient than the standard linear accelerators, but then again, these are offered in certain radiation centers. Brachytherapy is a different approach of administering radiation, which is called the seeds. Basically, under general anesthesia, radioactive material is implanted into your prostate, which administers radiation over time. After a certain point, the radiation stops, and then the treatment is completed. So they are different in terms of how they're administered, but the external radiation, I'll start with first, as it's the more common application. It's done in fractions, meaning that in the past, it used to be a 45-day treatment. So a patient can only have a certain dose of radiation, which is broken into small doses. So that's called a fractionation. And the patients get this small amount of radiation every single day. So the conventional way was to do in the past 45 days, which is not very common nowadays. So it's usually a 20 to 28 days treatment. So you go every day, get your treatment about 5 to 10 minutes, and you go home. So it's a lengthy process in some cases. And a more novel approach that's commonly offered these days also is ultra hypofractionation, meaning it's a 5-day treatment. So you do get a higher dose within a 5-day period to do the treatment. And for these patients, to reduce side effects, a rectal spacer can be applied. So a rectal spacer is basically the blue colored item you see on the figure. It basically increases the distance between the rectum and the prostate so that the radiation side effects on the rectum is decreased. And this can be done in an office setting or operating room setting. It's a short procedure. It takes about 5 to 10 minutes. And, based on the diagram, you can see it's a similar procedure with the biopsy, obviously less needles. So the brachytherapy is basically, like I said, implanting the seeds into the prostate. So through a diagram, these seeds you can see on the upper right part of the figure. Multiple seeds are implanted within the prostate. It's kind of like surgery in the sense that it requires anesthesia and it's a 1-day treatment. It is an outpatient procedure in most cases, and about 14 to 20 seeds based on prostate shape and size are implanted. It's not for everyone. Patients with large prostates, patients with baseline significant prostate symptoms and large prostate symptoms, or patients who had enlarged prostate surgeries in the past, such as TURP surgeries or whole-up surgeries, they're not good candidates for it. In radiation treatment, the side effect profile overlaps with surgery, but there are some differences. Mainly the acute toxicity is what patients deal with in the initial period. The acute toxicity is in most cases managed with medications, and these are given by the radiation oncologist during the treatment to patients. In the initial period, prostates do get inflamed, get swollen. To simplify it, that can cause a difficulty in initiation of the urine stream, weak urine flow, burning, urgency to urinate, frequent urination, or pelvic pain can happen, especially early on. And this is because of the radiation's effect on the bladder. And like we mentioned before, the rectum can get affected as large bowels. So it can cause increased uric frequency of defecation, sometimes urgency go to the bathroom, diarrheas can happen, and proctitis essentially is the inflammation of the rectum. Patients do experience, fatigue because, again, this is acute radiation toxicity in the early period. So radiation oncologists do encourage like physical activity and exercise in this period to counter that. most of these symptoms subside and hopefully go away in the short period, usually within the first 3 months. But there are some late toxicity. So radiation is different from surgery in the sense that with surgery, we do an immediate treatment, remove the source from the body. So surgery doesn't have effects after it's done. Whereas with radiation, the effects persist with the patient on an ongoing basis. So tissue changes do happen within and around the prostate in most cases. And the late toxicity means symptoms that happen sometimes years down the line. They're not reversible, but with medications, we can suppress them. So the rectal side effects can be persistence of the symptoms I mentioned in the past slides. Frequent defecation, incontinence, diarrheas can happen, which in most cases can be controlled by drugs like Imodium. Sometimes bleeding can happen from the rectum, which may require treatment by the GI or general surgery doctors. Same thing can happen to the bladder in the sense that symptoms can persist. There are patients who urinate urgently quite often every hour for the rest of their lives. These are more severe cases. In most cases, it's worse than the baseline, but it's manageable by the patients. And like I said, erection problems can happen with radiation as well. Penis shortening can happen as well because of the effect on the nerves and the vessels I mentioned during the surgery slides. In some cases, patients' urethras can get narrowed. This is because of radiation side effects. These can be tricky to manage and affect patients' quality of life. Bleeding can happen. Usually, it's minor and self-limiting. In some cases, it can be severe enough that patients may require surgeries. And in worst-case scenarios, even bigger surgeries to remove their bladders. These are when it gets to the worst-case scenarios. Secondary cancers are reported to be less than 1%, but these are possible side effects. It can take a decade or more to see these effects. So a patient in his 50s may have a high risk of dealing with these late toxicity as opposed to a patient in his mid-50s. So in terms of, which one to choose, I guess we'll get into that later, but both treatments are efficient. And we offer these treatments if a patient has a 10 years or more life expectancy, and the treatment is individualized. So not every patient is a candidate for all of these treatments. For some patients, there's an easier decision to choose one. For some patients, it's not that easy, and patients do get to make these decisions. Sometimes we use nomograms, which are risk calculators. These are numbers I put for an imaginary patient. What it does is it compares your information to other people who's had similar PSA levels, similar age or biopsy characteristics, and it can give us some ideas as to what the success rate for surgery is. In this hypothetical patient, there's about 5-year success of 82% with surgery, for instance. But I always like to end my consultations with the top row, where the survival rates are usually very good. Even if your one treatment fails, then you get the other treatment. With the modern tools that we have in our arsenal, patient survival numbers are pretty good. I don't want to go too much into statistics or details, but I just put this one diagram, which is a survival graph. And the all-cause mortality means a risk of patient from dying from anything. And the blue lines is overall cause mortality, and the orangish dots is about the prostate cancer. So as we see, there's a lot of patients who have prostate cancer even at 18 years after surgery, but that they die from other causes. So in terms of, radiation or surgery, it's hard to compare them. The graph I had was from a surgery study. It's hard to compare because the criteria for success is different between these treatments. I guess I don't want to go into too much details to confuse anyone, but because the success criteria or recurrence criteria are different, it's hard to compare these two. Overall, for a patient, there are certain factors to consider, patient's age, their Gleason scores, baseline erection qualities, past surgical histories, past radiation histories, imaging findings, prostate volume, anatomy, patient's body habitus, genetics tests. These all factor into decision making. Obviously, there's always a physician bias because both us and the radiation oncologists, we trust in our craft, we work hard on it. And sometimes there are patient priorities or bias too. I do frequently hear stories such as my neighbor had radiation, had a horrible experience, and patients may be biased, but radiation may be a good option for that patient. So I'm going to leave the stage to Dr. Olivares, who's the director of our focal therapy program, and he will talk to you about more newer and exciting treatments.
Thank you, Dr. Beksak. Nice presentation. I want to welcome all the people that is already connected. If you are dealing with prostate cancer, you have a relative dealing with prostate cancer, hopefully we're going to bring you some lights to enrich the conversation. So why we're talking about focalized treatment? Because we all agree that PSA screen save lives. So if you are in a high-risk group because race or family history, you have to start around 40 getting the PSA. If not, around 50 is a good idea. But unfortunately, the PSA is prostate-specific antigen. That is not the same that prostate cancer-specific antigen. So we are diagnosing some cancers that probably they are not going to put you in risk, in terms of mortality. So it's a good idea to be able to provide a middle ground alternative between observation and a radical treatment that Dr. Beksak just discussed. Also, we train a lot to remove the prostate as urology, as a surgeon, but we still see some detriments in the quality of life that can alter significantly quality of life if the patient is leaking or the patient has erectile dysfunction despite of our attempts. And also, we are experiencing better ways to diagnose prostate cancer. In many centers, we are getting prostate MRI, as a Dr. Bessart and Bacon pointed out. So it makes sense that if we are seeing the prostate better and we can map the extension of the prostate cancer, what if we can provide a treatment directly targeting the area that we are diagnosing? The game changer, as I mentioned, was the multiparametric MRI. Nowadays, instead of going blindly, poking the biopsy, poking the prostate, hopefully to catch the area with cancer, we can see the area concerning for prostate cancer. So your urologist will focus the attention in a specific area to diagnose cancer. We can use prostate MRI information plus the biopsy, the fusion capabilities of the biopsy to plan treatment. So we can export that information and using a map, like a map, to drive the treatment. Focalized treatment aims to eradicate one specific area with significant prostate cancer. As my colleague mentioned, not all the prostate cancer are the same. We have mainly three types. The high-risk prostate cancer. Unfortunately, the great majority of the patients that must deal with the cancer outside the prostate that we call metastasis are coming from the high-risk group. The other type is intermediate prostate cancer. We know that because the shape of the cells, you're going to hear the word Gleason. That is mainly that our pathologists can determine the morphology, a fancy word to say the shape of the cells. And if you have a Gleason 7, you are going to fall in the intermediate group. Intermediate group means for us that needs treatment, that in select patients we can just keep an eye to monitor that, but most of the time needs to be treated. But if the cancer is in one specific area, we can selectively destroy that area. And just for completion, as my colleague mentioned, low-risk prostate cancer tends to be very lazy. That means it's a cancer that tends to stay inside the prostate, and we have robust data that we can just keep an eye on that. So the question that make a lot of sense, so who is the right candidate for focalized treatment? As I mentioned, intermediate prostate cancer. If you are dealing with Gleason 6 or low-grade prostate cancer, Even though the word cancer is a very ugly word, I would say that it's pretty safe to keep an eye, and most of the time, you don't need focalized treatment. Secondly, if you are in active surveillance for intermediate prostate cancer, even though shows or you can hear tempting from the beginning, we know that if the patient is being monitored with intermediate prostate cancer, it's very likely that at some point will progress and will need some kind of treatment. The MRI must match the location of the biopsy because we need a clear target. We are going to discuss in this short period of time several energy, but the main concept is that we need a clear target to deploy the energy to that specific area of the prostate. Who cannot have focalized treatment? If unfortunately the patient is dealing with the cancer going beyond the external capsule, we cannot do something focal in the prostate when the cancer is spreading regional or at distance. Secondly, we have image, PET-CT, PET-PSMA, and MRI that can tell us precious information in terms that the risk of extraprostatic extension, the involvement of the seminal vesicle, that kind of patient, we cannot offer focalized treatment. Prostate cancer tends to be multiple spot, we call multifocal. So if the patient has clinical significant cancer, meaning grade group 2 or Gleason 7 or more, throughout the prostate, there is no reason to focalize, just treat one specific area. Most of the time, we have to do whole gland treatment like surgery or irradiation. The apex is the area that is more away to the base, more away to the bladder. And unfortunately, if the cancer that the patient is dealing with, it's too apical, it's too close of the mechanism of urinary continence. So we are very careful because the location matters. So if the cancer in your biopsy looks apex, probably your urology who offer focalized treatment will take a lot of look of the MRI to see if there is some distance where we can preserve the mechanism of urinary continence. Focalized treatment, by definition, is a balance. We go a small destruction to preserve the function and make sense to use all the image that we have nowadays available. We have to accept that in the multifocality will be one we call index lesion, that is the predominant lesion, the big chunk of cancer in one specific area, which we chance to think that it will drive the aggressiveness of the tumor. So if the patient has big volume grade group 2 prostate cancer and we destroy, we can keep an eye and offer active surveillance in the rest of the prostate. Of course, this comes for a long conversation because the preservation of quality of life must be a high priority, even though we can see cancer coming back, especially in the area that we are not gonna treat. In terms of the energy, there are different energy that is able to do that. We can have to do between the legs, between the perineum, through the rectum, through the urethra, inside the MRI, outside the MRI. But the main concept here is like the energy must be tailored of the location of the cancer, the patient expectation, the aggressiveness of the cancer. Most of the energy work very well when it's the appropriate energy for the patient. So when I see in my clinic in a regular day, the patient that is coming, that is dealing with prostate cancer, interested in focalized treatment, most of the time I tell you that the patient will not sleep at the clinic, at the hospital. Most of the time it's an outpatient procedure. The risk of incontinence in selected patients that are candidate is very low. Most of the patient will see, because the swelling, the inflammation, some increased urinary frequency or weak urinary stream that lasts 2 or 3 months, but after 6 months, most of the patients are fine. Erectile dysfunction, also 2 phases. Make a lot of sense that we can preserve very well the nerve that runs the erection, but we are using the word cancer many times during the time frame of the surgery. So nobody is very interested in sexual activity. After 3-4 months, the patient can resume the normal life. A typical misconception is like the volume of semen match the quality of the erection, and are completely different. So even though we destroy a small area of the prostate, the great majority of the patient can see less semen coming out during the climax, but the erection, the libido, the desire to have sexual activity remains the same. Infill means that when we do a biopsy in the area that we treat, we are very confident that most of the time we are successful. Science can, when you are involved in science, you tend to be more humble in terms that we don't have all the answer. Sometimes we finish our job very optimistic, and we can see some reoccurrence in the area that we treat. Most of the time, we go back and we learn from that lesson to try to reduce that happen again. Approximately 20% of the patient can develop cancer in the area that we are not going to treat. But remember that the patient candidacy is very important. So that patient already have an MRI that demonstrates no cancer in the other side, has a biopsy that also confirmed not cancer on the other side. So if you did a correct patient selection and the patient develop more cancer in the future, most of the time is low volume. Remember the lazy prostate cancer, that we can just keep an eye on that. And all the patients from the beginning, when we discuss focalized treatment, we tell that he will need an MRI and biopsy to confirm that everything is going into the right direction. With that, I just want to give the room to Dr. Brooks to talk about survivorships. Thank you.
All right, perfect. Thank you, Dr. Oliveras. My colleagues have spoken about the first 2 steps in this prostate cancer journey, that being diagnosis, followed by treatment. And survivorship is really that phase of treatment, that phase of monitoring after treatment. You know, our goals as urologists are always to keep you safe from your prostate cancer while, maintaining quality of life. So post-treatment issues are significant and need to be addressed with the same tenacity as both diagnosis as well as the treatment phases. So our goals are really to, again, address all of your needs following a prostate cancer treatment. It's really that period transitioning from the active treatment to daily post-op life. What complications am I going to have? How's that going to impact me both physically and psychologically? How's that going to impact, my relationships with my spouse, my family members, etc. There's several components to this that we like to focus on. One, of course, is the education piece, making sure both you and your family understand what to expect after treatment. Secondly, the surveillance component, of course, after prostate cancer treatment, the cornerstone rather of surveillance is PSA testing. So depending on which treatment you have, making sure that you understand what we're looking for, how frequently this PSA testing is going to happen, and then, of course, what options we have if we ever see a concerning PSA rise. And finally, we're responsible for making sure that your primary care providers understand what you've had done, what our expectations are going forward, so you have a seamless post-treatment care process. Specifically regarding PSA testing, it's different after radical prostatectomy versus radiation. We like to see the PSA is undetectable after prostate removal, meaning less than 0.03. We'll check that every so many months for really your lifetime, and that's where we want to see it. After radiation therapy, it's a little different. The PSA will slowly decrease over time, at which point it'll reach what we call a nadir, and then at that point we'll kind of see it ebb and flow. As long as it's staying stable, you're in good shape. There is something called PSA bounce, which can happen where we see a small, maybe quarter to half a point rise in PSA, typically 12 to 24 months after treatment, which then returns to your normal level, and that's not indicative of recurrence, but something that we're conscious of. Imaging is done, rarely, only in situations where we feel that we have a recurrence and it's necessary to help future planning. And importantly, individual survivorship care plans are made where, again, making sure you understand, any signs of recurrence, which typically there aren't any signs with prostate cancer. It's just PSA monitoring. But again, making sure side effects and their effect on daily life and things that we don't typically think about, financial consequences of, missing work, et cetera, are addressed. As far as managing side effects, I think all of us who've been doing this a while understand that while the physical side effects, which we discuss with you pre-treatment, are significant, and again, can include incontinence. We do encourage pelvic floor physical therapy either before or after treatment to aid with that. Sexual dysfunction is obviously high on everyone's list of concerns, and penile rehabilitation therapy is encouraged, especially after radical prostatectomy, in the form of either oral medicines like Cialis, Viagra, vacuum erection devices, or even injection therapy to help speed up recovery of erections. And then, hormonal related side effects. Sometimes if you have radiation therapy, or radiation oncology colleagues want you on hormonal therapy for anywhere from 6 to 24 months. So addressing those side effects is important. But just as important is the psychological side effects. Obviously a diagnosis of prostate cancer is an extremely emotional situation, invokes a lot of anxiety. And after the treatment is done, I think a lot of folks have a sense of relief, but then the other starts, and that's concern about the future and concern about recurrence, et cetera. So I think we're all aware of this, and it's incumbent upon us to address this at follow-up appointments and make sure we're answering the questions that you have. About a quarter of patients definitely experiences increased anxiety, and up to 10% actually suffer from major depressive disorder after these diagnoses and treatments, especially if you're undergoing hormone therapy, as low testosterone can invoke certain mood alterations and effects on personality. In general, I think one way to help alleviate some of these psychological factors is just general health maintenance, making sure you're sticking to a good diet, exercising regularly as a method of relieving stress, weight management, smoking cessation. All of this plays into, I think, a healthy post-treatment frame of mind. And again, it's incumbent upon us to make sure that your primary care physicians or advanced practice practitioners are up to date on where you are in your post-treatment journey. This was mentioned earlier. I just brought it up there. Screening for secondary malignancies. There is a slightly higher risk of secondary malignancies after specifically radiation therapy. Both bladder and colorectal, it's low, maybe in the 1% up to 2% range. It doesn't require any increase in screening frequency, but it is something to be aware of. In summary, after all of our treatments, we're going to follow your PSAs. The frequency with which we will check that depends on your both your treatment modality as well as how aggressive your cancer was. Again, standard guidelines for other cancer screenings, again, encourage healthy habits and offer psychological support services as needed. All right, that's all I have. I think we've got some time for some questions.
Yeah, I guess I'll take over from here. Excellent presentation, Dr. Bro. I've been reading some of the questions presented by the audience, so maybe we can go through them quickly. I guess the first question is, I'm 78 years old. My father had prostate cancer. My trends are low. Should I continue PSA screening? When should I stop? Maybe Dr. Baki, you can pitch in.
Yeah, I think the most important thing is to think about individual health and individual risks, and your individual preferences. 78 years old is when most of us is past where most of us would screen, and that's past where most guidelines would suggest screening. However, with a strong family history, some patients might warrant from testing even past where most guidelines are. Although 78, we have to remember that prostate cancer, we're talking on 5, 10, 15-year horizons, depending on how aggressive it is. So the burden of screening for you might not be worth it, especially if your PSA has been very low in the past when it's been checked. It doesn't tend to spike suddenly, even with aggressive cancers. Without meeting you and talking about your other health concerns, I think the important thing to keep in mind is it's unlikely, even for very healthy patients, to be worthwhile beyond the age of 70, but there's exceptions that we encounter all the time.
Okay. And another question is, what about PSA relative to prostate size? Can other factors increase PSA? Dr. Schwan, would you like to maybe pitch in about PSA density or other markers in this situation? We can't hear you.
I can take it while he works on that. Yeah, so PSA density is a marker that we use. We calculate the PSA and divide it by the volume of your prostate. And that's another reason MRI has been so helpful for us, is we get a good determination of what the size of your prostate is. On different extremes, very, very elevated PSAs are still likely to indicate some sort of problem, whether it's a prostatitis or an infection, or cancer, because even in a large prostate. But certainly we try to tailor our cutoff numbers for further investigation based on both age and prostate size, as we know that the PSA will scale with those.
So there's a question, I'll merge two questions into one. How does regular PSA differ from ultrasensitive PSA? And the other question is, if prostate makes PSAs, why is PSA tested after prostatectomy? Dr. Bro, would you like to pitch in?
Yeah, sure. So that is true that prostate cells are what make PSA. After prostatectomy, though, the concern is you could have, for lack of a better term, microscopic levels of prostate cells that are present after treatment. Those cells could potentially lie dormant for years and then start multiplying, dividing. The more prostate cells you have, the higher the PSA is going to be. So it's extremely important to follow PSAs lifelong after. While it's uncommon, it's certainly not unheard of for us to see PSA rise, years after treatment, after a prostatectomy, for instance, in which case that could indicate the presence of recurrence of disease. In that situation, it's typically, localized down in the pelvis, in which case additional treatment might be necessary, such as, external beam radiation. Post-treatment, ultra sensitive versus regular PSAs, I don't think it really, in my opinion, doesn't really affect things much, as long as the PSA is undetectable. That's really what we're concerned about. There are certain situations where it may influence decision making, but as long as I always tell my patients, as long as you see that less than caret, that's what we're looking for. Different labs can express PSA results differently, which can cause a little anxiety in folks. But again, as long as you see that less than caret, we can be pretty comfortable, rather, that you're disease free.
Okay. So if I choose radiation, can I have surgery in the future? And maybe I'll add, can I have focal therapy after radiation? Dr. Olivares?
I mean, surgery after radiotherapy. Radiotherapy leaves a lot of scar tissue, especially near the urethra where the urine passage. So we can remove the prostate after the radiation. The answer is yes, but the risk of urinary incontinence is higher. Secondly, if the patient has a reoccurrence, probably is a more aggressive cancer, so the risk of positive margin is also a little bit higher. So a good conversation with the patient is fundamental to try to determine that. Focalized treatment, as by definition, focalized means focal. So after radiotherapy, we have to map the biopsy to find a target. I'm not a big fan to do whole gland ablation using energy. If that is the case, I remove the prostate, surgically speaking. So if we have a clear target, inside the prostate, and all the staging, all the workup is negative for metastasis, the patient could be considered for focalized treatment.
So there is a question about MRI's 1.5 Tesla versus 3 Tesla, Dr. Schwen. We can't hear you still.
I can take that. So
Okay.
in the history of the MRI, we have mainly 3 transitions for 0.5 Tesla, 1.5, and greater than 3. And that means it's the field. That means it's how much noise the MRI suite accept. Nowadays, with more than 1.5, we are good. And remember that we also use fusion capability during the biopsy, so we can compensate more noise, not clear definition of the imaging during the biopsy.
So I had one nerve preserved during surgery. What is the advantage of nerve sparing on one side? Do nerves grow back? If so, how long does it take? Are the nerves necessary for erections? Dr. Bro, what do you think?
Yeah, I would say the nerves are definitely necessary for erections. Usually if you have a unilateral nerve sparing, it's due to disease. For instance, let's say you had Gleason 6 on one side of the prostate, but you had, more aggressive Gleason 8 on the other side. The surgeon may elect to just spare the nerves on the side with the lower risk disease. In general, the nerves do not regenerate, unfortunately. That's certainly one of the risks of prostatectomy. Although a nerve sparing can be performed, sometimes those nerves might be intimately woven into the prostate itself, and so could get removed or damaged at the time of surgery. That's the importance of postoperative penile rehabilitation and really trying to bring oxygenated blood down to the pelvis to try to speed up recovery. But it's certainly a frustrating thing for us as providers, and obviously you as patients postoperatively. But yeah, that's my thoughts there.
You're mute, Tuna.
Apologies. So another question. I had external beam radiation about 5 years ago. My stream is getting weaker and weaker. A recent of the urethra exam could not be done due to stricture. What are my remedies other than TURP? I guess maybe we can talk about what are the risks for this. Dr. Schön, did your microphone get fixed? Or? Sorry. Okay, maybe Dr. Baki, would you like to take this one?
Yeah, unfortunately, stricture disease is a risk factor after radiation. What you got to remember is that the tissue surrounding the prostate gets damaged and its ability to heal itself is reduced because of the DNA damage. Certainly, you warrant an evaluation by a urologist and maybe even a urologist who focuses on reconstruction of the urethra. The most common place for a stricture to occur after radiation is very close to the prostate, as that is where the radiation was aimed. However, it sounds like they were unable to do an evaluation of your urethra, which maybe that means that there is a stricture elsewhere. So certainly there are surgical options, and the location and length of the stricture are going to be what determines what those surgical options are. That can range from, as you mentioned, a TURP if it's very close to the prostate, or even a surgical repair of the urethra with some sort of graft. So I think there's certainly options available for people who run into that problem after radiation.
If there is recurrence after radiation, can you do radiation again? What is the impact of double radiation? Who would like to take this?
I can take that. All the salvage setting, meaning that the cancer that reoccur after the primary attempt, it's more difficult. And Dr. Bakey provided why is that? The lack of vascularization, so we don't can bring proteins, so you develop a scar tissue. So if the radiation fails, we can repeat the radiation mainly if the area where you have the reoccurrence was out of field, was not irradiated the first time. Most of the time, as you know, the seminal vesicle is the site when we can see reoccurrence after radiotherapy. So if that is the case, they can boost, they can retreat that area to reduce to try to kill the cancer. In select patients, they can boost with brachytherapy seeds the area that was previously treated with external irradiation. But again, most of the time it's a difficult procedure, so we have to be very careful in the patient candidacy to offer that.
So one question is, do less aggressive cancers become more aggressive sometimes? Is that why repeat biopsies are done on a patient with Gleason 6 patient?
Yeah, I mean, I would say, I'm not so sure it's a less aggressive cancer becoming more aggressive, or a separate site of cancer being present in the prostate. But if you have Gleason 6 cancer, you're on active surveillance. A reason why we do recommend, obviously, PSA testing every 6 months or so, repeat biopsies every so many years, is to document that we're not seeing any progression of cancer or any more aggressive cancer in the gland that might warrant intervention. As was mentioned previously, MRIs are also used now, so we can use that as a tool to maybe try to avoid biopsies in folks that are on active surveillance later in life, as long as we're seeing stability of the PSA, stability of MRI images. But yeah, that is the reason that repeat biopsies are often done, just to make sure that we're not seeing progression of disease.
Dr. Oliveros, there's a question. Is there one focal therapy treatment that offers less recurrence than the others?
Overall, when we deploy the energy to the right target, most of the energy are very similar in terms of outcomes, in terms of how successful they are. I would say that the main distinction about the energy is how big the lesion is. Most of the time we differentiate different confluent energy. And secondly, the location. It's different when the cancer, for example, is on top of the prostate, above the urethra. For sure, I'm not going to use an energy that I have to deploy from the rectum, because I'm going to have to pass the energy through the urethra. Secondly, the presence of calcification can limit some options. But overall, I would say that we have option because we don't have a clear winner. And I would say that most of the energy are very similar and highly successful to destroy that specific area of the prostate.
And I guess we have time for one last question. I guess there's been a few questions about incontinence after surgery. So there's questions about pelvic floor physical therapy, and if that doesn't work, what are the next steps for a patient to expect? Maybe Dr. Bro, this was your talk. If you can summarize that, and that would be our last question.
Yeah, sure. So again, pelvic floor physical therapy is an excellent idea for all folks undergoing prostatectomy. After that, if you have, again, incontinence can certainly take a while to resolve, up to a year. If you have persistent leakage, there are certain surgical procedures that can be done to try to alleviate the leakage, and it really depends on how significant it is. We look at how many pads you're using and or how many depends you're going through a day to determine if either a urethral sling is appropriate or something called an artificial urinary sphincter, which is typically done for folks with more significant leakage. There are certain urologists who specialize in this kind of surgery, and we'll generally refer you to them for further discussion if you're interested. But yes, there are certainly options.
I guess this is it for today. And thank you so much, Dr. Becky, Dr. Schwen, Dr. Olivares, Dr. Bro. And thank you everyone for joining us today. I hope this had been a very helpful and informative experience for all of you. I had some questions. I guess this will probably be available as a recording in the future, I believe in our website or maybe in YouTube. Stay tuned on that. Thank you so much for joining us today. Have a good evening, everyone. Bye-bye.